Hello, good day. I am Dr. Bangoy. I'll be talking about cardiac imaging and back to basics. So I'll not be talking about advanced cardiac imaging such as MRI or CT scan or 2D Doppler examination, which is conducted by the cardiologist. I'll be talking more about X-rays. Why? Because this is most readily accessible in almost all hospital and clinics, and it's cheap. And so let's go and review the basic anatomy of a chest X-ray. So before doing that, it's a word of caveat that before interpreting a chest X-ray, you have to see first how the chest X-ray was taken, whether is it in AP or PA view, because this would affect the level of confidence in calling whether you have any pathology, such as you have pulmonary congestion, whether your heart is enlarged or normal, because in AP view your heart is magnified, and most of the time your pulmonary markings will be prominent or dilated, because patients usually sick when the chest X-ray taken in AP view, and you might think that your pulmonary markings are prominent, and you might mistake it you have pulmonary congestion or you have presence of pneumonia. So let's go back and review the normal anatomy of a chest X-ray. So here you can see here, this is your aortic knob. Going down here, this is the main pulmonary artery segment, and this is your left atrial appendage, left ventricle, descending aorta. This is your superior vena cava here on the right side, and this is your right atrium, and here is the right pulmonary artery, and somewhere here is your inferior vena cava. On the lateral view, you can best see your right ventricle. It is positioned at the retrosternal space, and this is your ascending aorta, transverse aorta, descending aorta here. The posterior portion of your heart, on the superior posterior border of your heart, it is represented by your left atrium, and then the posterior inferior border of your heart, this is represented by your left ventricle. Now the most common cardiac measurement that we usually utilize determining whether you have an enlarged heart is the cardiothoracic ratio. So how do you measure that? You draw an imaginary line along the spine, and then you take the widest distance on the right side of your heart, and then you add the widest distance on the left side of the heart, and divide it with the widest diameter of your chest. So normally what we usually use is 0.5 to simplify it, but strictly speaking it is 0.45, and some books would say that greater than 0.45 or 0.55 you have a mild cardiomegaly, and greater than 0.55 you have moderate or severe cardiomegaly. So another cardiac measurement that we usually not commonly use is the vascular pedicle. Is said to be normal when it is within 48 millimeters, and greater than 53 millimeters they would say that patients are on cardiogenic edema. So we have to determine how the chest X-ray has been taken, just like I said, whether it is in AP view or in poor inspiratory phase or in good inspiratory phase. Why? This would affect really your judgment whether you have this patient has a cardiomegaly or pulmonary congestion. Just like what you see here with the same patient on the right side, taken in poor inspiratory pace, you can see the heart is magnified and the pulmonary vasculature are prominent, and there's some haziness in the lungs. But this was taken on the same patient on the same day, wherein taken in PA view and good inspiratory pace. You can see the heart is normal rather than enlarged, and the pulmonary vasculature are normal as well, and there's a what you call clear lungs and well expanded. So what do we look at in interpreting chest X-ray? We also not only measure the cardiac size, we also try to determine the pulmonary vasculature, whether they are prominent, dilated, or you have pulmonary congestion. So you have stages in pulmonary congestion. First, you have sepalization, and then equalization of the pulmonary vasculature. What is sepalization? Normally, the pulmonary vasculature are only prominent at the bases of the lungs, but however, when patients are having a congestive heart failure or mild congestive heart failure, the pulmonary vasculature on the upper lung fields would become prominent as well. So once the pulmonary vasculature on the upper lobes and at the lower lobes are almost equal in size and they're both prominent, so that's what you call equalization. Once there would be exacerbation of fluids into the interstitium, that's where you see already your curly B, curly A, curly C lines. So what is curly B? These are linear densities arising from the hilum and then stretch perpendicularly. And for curly A, these are linear densities obliquely oriented from the hilum. And for curly C's, these are crisscrossing of linear densities or lattice slide. So the most ominous sign among the curly lines would be curly C. So now let's determine the cardiac chamber. That will be how do we see it and how they are oriented, and once they enlarge. In right ventricular enlargement, the right ventricle enlarges in anterior, superior, and leftward direction, causing level rotation of the heart. So what do you see in PA chest X-ray? There's a straightening or convexity of the left upper cardiac contour. There will be upturn of cardiac apex. So rather than your cardiac apex would be pushed down, there will be uplifting of your cardiac apex. So left upper cardiac margin parallels left mainstem bronchus. There's increased distance between left upper cardiac margin and plus the left mainstem bronchus. Small appearance of rotated aortic arch and SBC, and large appearance of the main pulmonary artery segment. So this is the main pulmonary artery segment. This will become prominent or dilated. This is an indirect sign that you have a the right ventricular enlargement. So just like what I said earlier, the right ventricle is best evaluated in lateral view to confirm your PA findings for right ventricular enlargement. What you see in lateral view, you have a prominent convexity of the anterior heart border, which is greater than 1/3 the distance from anterior cardiophrenic sulcus to the sternal angle. So in right atrial enlargement, right atrium enlarges in rightward and posterior direction. In PA view, there will be greater than 5.5 centimeter from the midline to the most lateral right atrial margin here. So there will be dilatation here, and the most commonly used is the right cardiac border would be, there will be an increase in right cardiac border. So from the base of the heart up to the cardiac pedicle, vascular pedicle. So this would be increased greater than 50%. So for left ventricle enlargement, the left ventricle enlarges in posterior and inferior and leftward direction. In PAHS X-ray, there will be a leftward displacement of a downturned cardiac apex. Here, there will be compression of the left hemidiaphragm and gastric bubble. So in left ventricle enlargement, in lateral view, there will be increased convexity. If there will be a posterior inferior cardiac margin. Posterior cardiac margin projects greater than 1.8 cm posterior to the IVC, measured at the 0.2 centimeter above the intersection of IVC with right hemidiaphragm, or what we call the Hoffman-Rigler rule. So for left atrial enlargement, the left atrium enlarges in multiple directions. In what you see in PHS X-ray, right retrocardiac double density. Here, there will be a double density. So there will be splaying of the carina. Why? Because your carina sits on top of your left atrium. As your left atrium enlarges, there will be splaying of your carina. So the left atrial appendage is likewise enlarged here. There will be straightening of your cardiac border. So in lateral view, what you see in left atrial enlargement, the superior posterior cardiac of your heart would bulge or would be prominent. So let's go now to the congenital heart diseases. So to simplify or narrow down our differential diagnosis in congenital heart diseases, we try to qualify our CHD according to a cyanotic and cyanotic CHD. So under a cyanotic with enlarged main pulmonary artery segment, with increased pulmonary blood flow and increased cardiothoracic ratio, that means you have increased heart. These are the CHD conditions that with left to right shunt, the VSD, ASD, PDA, endocardial occlusion defect, partial anomalous pulmonary venous return. So in cyanotic with concave main pulmonary artery, we have the T lesions. We have the transposition of great vessel, truncus arteriosus, total anomalous of pulmonary venous return, tricuspid atresia without right ventricular outflow tract obstruction. So still under a cyanotic with enlarged main pulmonary artery segment, wherein there's a normal pulmonary blood flow or pulmonary vasculature, what you see in chest X-ray, with normal cardiothoracic ratio or normal heart size, with increased pulmonary venous hypertension. In left ventricular outflow obstruction, you have aortic stenosis, coarctation of aorta, interrupted aortic arch, hypoplastic left heart. With the one with left ventricular inflow obstruction, the obstructed TAPVR, total anomalous of pulmonary venous return, coarctate tratum, pulmonary vein atresia, and congenital mitral valve stenosis. So in cyanotic with concave main pulmonary artery segment, you have the right to left shunt. Again, you have the T lesions, the tetralogy of Fallot, tricuspid atresia, and the one with increased cardiothoracic ratio, with restrictive intracardiac shunt. You have the pulmonary atresia with ASD, without VSD, and pulmonary stenosis with ASD or with patent foramen ovale, trilogy of Fallot, Einstein anomaly, and congenital tricuspid insufficiency. So another way how to understand and predict what would be the cardiac appearance, or what to expect to see in a chest x-ray, we have to know the hemodynamics of each CHD. So in ASD, what you can see, what we know, you have atrial septal defect. So what happened in atrial septal defect? There will be a volume overload on the right atrium because of this defect. So what would be the first chamber that would be affected? Would be your right atrium. So what you see in chest x-ray, in ASD, in early adulthood, you have a right atrial enlargement. But later on, as they grow older, in late adulthood, they will develop right ventricular enlargement, and then they also develop pulmonary hypertension. So in early stage, in early adulthood, most of these patients are asymptomatic. So that's why they are detected late. So once they become symptomatic already on their late adulthood, especially around 20 years above, so they already have right ventricular enlargement, and some of them will develop already pulmonary hypertension. So what do we see? In ASD, in chest x-ray, you have uplifting of your left cardiac apex. That would represent that you have right ventricular enlargement, and there's increase in height of your right atrium, and your main pulmonary artery segment would be prominent as well. So as they grow old and they develop already pulmonary hypertension, so the right ventricle would be more prominent or enlarged, and the main pulmonary artery segment will also be dilated, and the right atrium will be severely enlarged as well. So this is the most common congenital anomaly or congenital heart disease for patient greater than 20 years of age, and so on. So in VSD, so you have a ventricular septal defect, so there will be a volume overload on your right ventricle, and then volume overload on your pulmonary systemic circulation as well, pulmonary circulation as well. So the first chamber that would be affected first or enlarged would be your right ventricle, and then followed by your left ventricle when you develop already pulmonary hypertension. And later on, this patient will develop also right atrial enlargement. So what do we usually see in VSD? You have a left atrial enlargement, prominent pulmonary artery. Your left ventricle would also be enlarged, right ventricular hypertrophy. There's increase in pulmonary blood flow. So this is the most common congenital heart disease, comprising around 25 to 30%. So the most common is the membranous, perimembranous VSD, around 75 to 80%. So in PDA, what you see, you have a large left atrial enlargement, enlarged pulmonary artery segment, there's increased pulmonary vasculature, enlarged right ventricular and left ventricle, you have enlarged ascending aorta, and prominent ductus infundibulum. Those days, they would say that they will see a calcification at the area of your pulmonary artery that they call the railroad's track sign. But These days, when we diagnose a patent ductus arteriosus, it is mostly diagnosed in 2D echo, and we can also diagnose this in MRA and CTA. So in PDA, there's a persistence of left 6 aortic arch. This comprises around 9% of all congenital heart diseases. This is associated with prematurity of birth, asphyxia, high altitude births, rubella syndrome, coarctation, VSD, trisomy 18 and 21. So in tetralogy of Fallot, you have right ventricular hypertrophy, pulmonary stenosis overriding aorta, and VSD. So these patients are cyanotic because of there's admixture of blood, of oxygenated and non-oxygenated blood. So another way how to diagnose in chest X-ray of congenital heart diseases is by pattern recognition. In tetralogy of Fallot, they said that the heart of these patients would appear like boot-shaped heart, or Coeur and Sabot. There will be a concavity at the pulmonary artery here, small or absent PA. So there will be decrease in pulmonary blood flow, so you don't see much pulmonary vasculature because of the shunting, and then pulmonary stenosis as well. So in TOF, they're under development of pulmonary infundibulum secondary to unequal partitioning of the conus truncus. It is 8% of all congenital heart disease, most common with cyanosis after 1 year of age. So you have different subtype of tetralogy of Fallot. You have the pink tetralogy, wherein you have infundibular hypertrophy in BSD. In pentalogy of Fallot, you have tetralogy and ASD. Trilogy of Fallot, you have pulmonary stenosis plus right ventricular hypertrophy and patent foramen ovale. See, in total transposition of great vessel, so your aorta would be arising from your right ventricle, and your pulmonary artery would be arising from your left ventricle, rather than the normal anatomy wherein your aorta would rise from your left ventricle and vice versa. Your pulmonary artery would be coming from the right ventricle. So for this patient to survive, they must have compensatory shunt. Most of them, they do have ASD and BSD. So there will be a mixture of oxygenated and non-oxygenated blood. So clinical presentation of patients are cyanotic. So what do we see? Again, in pattern recognition, what we see in chest X-ray for patients with OGB, it said that the heart appears like it is egg on its side. There's an enlargement within 2 weeks of life of the heart. The right heart enlargement is present. There's an absent pulmonary trunk in 99% in what you see in a chest X-ray. So complete transposition of great arteries, or TGA. The aortic originates from RV, and the pulmonary artery originates from LV. Normal position of atrium and ventricle. So in Einstein anomaly, there's enlarged right atrium, and there's atrialization of your right ventricle, and most of them, they do have ASD. So what do we see in Einstein anomaly? Because of atrialization of your right ventricle, so The heart appearance would be box-like or funnel-like shape. The right atrium and right ventricle are enlarged. There's an extreme right atrial enlargement. Your inferior vena cava is and azygous vein are dilated as well. Excuse me. Hypoplastic aorta and pulmonary trunk. Normal left atrium. So there's a downward displacement of septal and posterior leaflets of dysplastic tricuspid valve with ventricular division into a large superior atrialized portion and a small inferior function chamber, or the right ventricle is very small. So in hypoplastic heart syndrome, so usually this is seen in early at birth, and patients are mostly symptomatic at birth, and most of patients they don't survive in early childhood or in neonate. So you have a very small heart, what you see, just like what you see here in this chest X-ray, hypoplastic heart. The left ventricle is small. So in hypoplastic left heart syndrome, most common cause of CHD in neonate, responsible for 25% of all cardiac deaths in first week of life. There's an underdevelopment of left side of the heart characterized by aortic valve atresia, hypoplastic ascending aorta, hypoplastic or arthritic mitral valve. There's an endocardial fibroelastosis or small left atrium, small left ventricle, and small ascending aorta. So in coarctation of aorta, you have stenosis or stricture of the thoracic aorta. This is most commonly after the take-up of the left subclavian artery. Again, this is less likely diagnosed in a regular chest X-ray. The best way to diagnose, to document that you have this patient has a coarctation of aorta, is by doing CTA or MRA, and a good screening procedure to do is to request for a Doppler examination. So mostly the chest X-ray appearance of the patients with coarctation of aorta is normal. They say that there's a reverse 3 sign, but that's really very hard to see. So this is the most common cause of congestive heart failure in neonate after a hypoplastic left heart. Localized coarctation of aorta in adult or postductal, juxtaductal type. It's most common, short, discrete narrowing close to ligamentum arteriosum. In tubular, there's a hypoplasia or infantile type, or hypoplasia of a long segment. So in another congenital heart disease, or the total anomalous of pulmonary venous return, the pulmonary drainage or pulmonary circulation drainage with the entire goes back to the right side of the heart or right atrium. So there will be a volume overload on the right side of your heart. What would you will expect that the right side of your heart, right atrium and right ventricle would dilate, and the superior vena cava would be dilated as well. So again, we can diagnose total anomalous pulmonary venous return by pattern recognition. What do we see in chest X-ray with patient with total anomalous pulmonary venous return? There will be a figure of 8 or snowman sign because of a dilated superior vena cava and left vertical vein. So the right atrium and right ventricle will be dilated because of volume overload. There will be a normal left atrium because of the ASD will act as a escape valve. there will be increased pulmonary blood flow. So in total anomalous pulmonary venous return, you have anomalous connection between veins and systemic circulation, systemic veins secondary to embryologic failure of the common pulmonary vein to join the posterior wall of the left atrium. 2%, this is comprises of 2% of all congenital heart diseases. Mostly they are symptomatic in the first year of life. This is associated with ASD, patent foramen ovale, necessary for survival. You have several types in TAPVR. You have the supradiaphragmatic type, type 1, supracardiac type, which is one of the most common, around 52%. The pulmonary vein drainage into the left brachiocephalic vein, or right and left with right and left persistent superior vena cava and azygous vein. In type 2 or cardiac type, comprising around 30%, the pulmonary anomalous pulmonary vein drains into the coronary sinus around 80%. So you have a right atrial enlargement. And around 20% you have the subdiaphragmatic type. So another congenital heart condition is the partial anomalous pulmonary venous return. In partial anomalous pulmonary venous return, it's only a portion of your lung with anomalous pulmonary vein that drains back to the right side of your heart or right atrium via the coronary sinus or superior vena cava. So what do we usually see in partial anomalous venous return? They would say that there will be a dilated or prominent anomalous pulmonary vein. So this would appear just like a sickle or scimitar sign here. So this less common. This only comprises around 0.3 to 0.5% of CHD. This associated with ASD around 25%. And there's a hypogenetic lung as a component of congenital pulmonary veno-lobar syndrome. So now to recap, to diagnose congenital heart diseases, you have to know the table again, and hemodynamics, as well as in the pattern recognition of the heart in a chest x-ray. So in acquired cardiovascular diseases, so knowing the hemodynamics and what is expected in cardiac findings and pulmonary findings, how the heart would behave in certain condition of heart diseases. So you would expect what cardiac chamber would be dilated or enlarged in a chest x-ray. So most adult cardiac diseases, this is secondary to hypertension, coronary artery disease, atherosclerotic vascular diseases as well. So in intrinsic aortic valve disease, you have the list here. You have congenital bicuspid valve, rheumatic endocarditis, bacterial endocarditis, and aortic valve prolapse. In primary disease of aorta, there's a dilatation of aortic annulus in such conditions such as syphilitic aortitis, rheumatoid arthritis, and in trauma, you have lacerated aorta caused by hypertension and trauma as well. So what do you expect when you have aortic valve disease? So in aortic valve disease, because of resistance or pressure overload, so the first cardiac chamber that would be affected or expected would be your left ventricle. So as your left ventricle hypertrophy and later on enlarges, so your aortic valve annulus would dilate, and as well as your mitral valve annulus would also dilate, and later on this patient would develop some incompetent valves. So there will be because of incompetent valve, there will be a